Hi everyone, I'm Nadine. I am currently working at the Gateway Busamed Hospital. I see a lot of hospital and rooms patients, and today I'm going to speak to you about coding. So as you know, it's a very important part of our profession to code ethically and correctly. So this presentation was actually intended for quite an interactive presentation. So what I'm going to do is I'm going to try and tackle all the questions or queries that you guys might have, or misconceptions. Obviously, if I don't cover everything, please feel free to contact me on Nadine at hgphysio.co.za if there's any queries. That being said, you must know your coding. It is crucial that you understand why you're coding, for what reasons. It really, to make it as ethical as we possibly can and to be as accurate as we can. All right, so I'm gonna steam ahead. Before we get on to coding, the first thing that's very important is your note keeping. So note keeping is crucial to actually explaining what your codes mean. So if you don't have good note keeping, already your coding is not legitimate, or it's, we can't back up your coding. So please make sure that you are following all these points that I go through. Okay, so the first one is that once you have written your notes, you are unable to actually change them. So it is crucial that you are accurate and concise when you're writing your notes. A lot of problems with people being able to read notes, so ensure that you are writing legibly. If you really know that you have bad notes or bad handwriting, and maybe try and go to caps, or not write in cursive, try and write more in print. It is actually something that's very important. We all do write differently, so make sure that you do write clearly. All right. That being said, notes should include the following. So the date, your start and end time. Sorry, I didn't write end time there, but it must be start and end times. And the place for every consult. So place usually is written on the front of the file, but if you're in the hospital, it would be advisable then, for example, on my side, it would be Gateway. So for every consult, you should be writing those three things, okay? Obviously, it also should include the patient's personal details, so John Smith, their history, that can obviously be in the initial assessment, your full assessment, your proposed clinical management. Then we get your SOAP notes, which is definitely your subjective, your objective, your treatment, and your plan of treatment. Details of referrals, reaction to the treatment will be, obviously after your treatment or in your plan. And then, like x-rays, test results, etc., etc. Please note with the note keeping as well to write your rehab time at the end. We've made a rule that you must write your rehab time. So for example, if you've done a 40 to 45 minute treatment, then you would write their rehab time 40 minutes. So it is legible to write that, depending on your coding. So it, even though your 501 is only a 30-minute rehab code, it still justifies you rehab, which would include your spinal mobs, your neural mobs, whatever, interferential, that will all be included in your 40-minute rehab time. Okay, so please write rehab time, actually write it out, rehab time 40 minutes. Okay. Another thing that people don't realize is that you have to sign at the end of every SOAP note that you do. but include your initial and surname. So if you're only signing, please write your initial and your surname as well. If you're only writing initial and surname, please sign. It is crucial that that it is all written out and clear, especially if we get any clawbacks and they draw the notes. It should all be there. So these small nitty-gritty details you need to make sure that you are doing, okay? If, for example, you need to edit your notes, unfortunately, it does happen. I make mistakes sometimes. I'll be writing frantically and I by an accident write knee instead of hip, for example. So then you're not allowed to use Tipex or whiteout or anything like that. You have to just draw a single line through the change, sign by the change, and write in a reason for the amendment, okay? So it's just being honest. It's just so that it's clear and concise, so that you can actually, you know, make sure that we are as thorough as possible, okay? Getting on to standardized abbreviations. So that is actually according to the SASP abbreviations. So all of you should just Google what the standardized abbreviations are for from SASP, and actually note how many abbreviations you're actually using that aren't included in there. So what we've noticed is that we actually have a lot of abbreviations in our practice that we are not actually using. So what you need to do is actually make sure that you either amend your abbreviations, because some of my abbreviations are different to the standardized abbreviations. So amend the ones that you are maybe potentially using that aren't actually the standardized ones. And then secondly, every practice is now going to speak amongst yourselves and actually make your own list of abbreviations, and actually put it up in your practice, on your notice board, that those are your included standard abbreviations on top of the SASP abbreviations, okay? So for example, we are using the C with a dash as with. So that means with for us, all of us use it. So if you haven't done so if you don't have a list of your standardized abbreviations somewhere that you know to refer to, every page that you are using a standard abbreviation, at the top or bottom of the page, you have to write C with a dash on top equals with, so that it is noted that that abbreviation means with. So that's just one example of many that we are using, and you need to make sure that you are being specific with that, okay? So please be aware of your standard abbreviations. All right. Then another important one is no disapproving comments. So please be professional and concise. So obviously an example of not to use is the fat lady couldn't get out of the bed on her own. Guys, obviously, I'm sure all of us don't do this, but it is important that you are professional. So you would put in your objective that the patient has a high BMI and difficulty getting out of bed independently. There are ways to write professionally. If you are unsure, ask your colleagues, ask your superiors. Please make sure that you are not writing any disapproving comments, because people are going to see your notes or potentially will pull your notes. And that's something important to remember. I know we all do have difficult patients. It is not abnormal to have a difficult patient, but just when you do document, you are documenting it professionally and with no disapproving comment whatsoever. All right. And then lastly, our notes are to be kept for 6 years after being dormant. So that means that if you have not treated the patient in 6 years, then you are allowed to send them through to be shredded. But if you obviously treat them after 5 years or 2 years, then the notes then kept are from that last date of treatment for 6 more years, okay? In terms of minors, the notes are to be kept until their 21st birthday. So if you've started treating them at 1 month old, they're to be kept for 21 years. And then your patients above 80 and your mentally ill patients, those are to be kept until they pass away. All right. So everyone, please make sure that you are doing all these points, you are doing good notes, and you're making sure that you're being as concise and as professional as possible, and that it's legible. All right. Sorry, one last bullet that's not on here is that when you've treated the patient, you have to write your notes within 24 hours of seeing the patient. So if you are not doing so, please get into the habit of just writing your notes at the end of every day. We all should be doing that anyways. I know times get busy, but you need to make sure that you're writing them within 24 hours of seeing the patient. All right. Moving on. So your common coding rules, I'm just going to actually speak about the major big codes that we normally use. So everyone always has all these misconceptions about the big codes. So we're just going to actually just make it clear for everyone to understand. It's time-based, your 5 codes. So your 501, 509, 503 is the most common that we use. And they are all time-based. So if you're not aware of that, you need to make sure that if you are using these codes, you are spending that amount of time. That's what time-based means, okay? So your 501 is your rehabilitation code that requires undivided attention for 30 minutes, okay? So if you're spending 20 minutes, if you're spending 28 minutes, you are not allowed to use a 501. All right, a 501 can be used with something else within your 30 minutes. So for example, if I'm seeing a knee replacement and I'm doing his bed exercises, I'm doing his knee flexion mobs in sitting, we're bending to try and gain that 90 degrees. So we're doing mobilization with movement, and I'm giving him the little bit of grade 3, grade 4 pushes to get him to the 90 degree mark, and I get him up and we walk to the toilet, and then we walk back, and I've taught him how to use the crutches, and explain to him that he must do heel toe and he can put some weight onto the leg, etc., etc. Then my coding, within those 30 minutes, I can use a 501 and a 405. The 405 has been causing a lot of clawbacks at the moment as well, so it is crucial that you understand that if you're not mobilizing a joint, so if you're not writing it or doing it, obviously, if you're not doing it and not documenting that you're doing it, you are not allowed to use a 405. So, for example, if an elderly lady, she's just in hospital with a lung infection, and we are, no longer doing chest, we're just doing deep breathing exercises, and we're doing a bed program. And we're getting her up and we're walking her around the ward, but she's a slow old granny, and she's doing very well, but she's struggling, so we take quite a bit of time. So the treatment's 30 minutes, but I can't use a 501 and a 307 together because of the deep breathing, because it's included in our 501. So for my 30-minute treatment, I'm only allowed to use a 501. There's no other code I can put with that because I'm not mobilizing the joint. The 305 and the 307 is inclusive of that 501. Okay, so it's crucial that you understand that. Then it comes to the 509. So the 509 means that you are spending an additional 15 minutes to your 30-minute treatment time. So then you're doing a total of 45 minutes of undivided physiotherapy, okay? What has been used in the past is that people have been doing a 501 in the morning, and then in the afternoon they're coming quickly to see their patient for 15 minutes and using the 509 at a separate time slot. So this 501, 509 needs to be put together in a single treatment episode, okay? So it is put together. So it would most likely be a patient that you are actually getting up, going for a walk, doing stairs, coming back, doing a full bed program, going through all the education, all the advice, how to go into the shower, how to use the toilet, how to get into the car. Your full rehab time as 45 minutes, okay? So please note that. And then lastly, your 503 is specifically for rehabilitation of your CNS disorders, so your central nervous system disorders, for a full 60 minutes. No other modality can be charged actually with a 503. So for example, your 501, where you can include a 405 or a 310 or a 301 or a 300, with your 503, there is no additional code that can be put with this rehabilitation code. And it has to be 60 minutes, okay? So unfortunately, this has become a little bit of a problem, especially when it comes to the subacute rehab places, when, for example, they actually are unable to see the patient for a full 60 minutes. For example, one of the questions came up that if the patient was soiled, they couldn't necessarily see the patient, or their endurance was a little bit lower, so those kind of things. So what we suggest is that I must admit, a lot of the time I help with bathing, with changing linen, those kind of things. I'm not doing it intentionally to spend more time with the patient, but it is still helpful to actually be a bit more hands-on, because you're teaching either the caregiver or even a family member might actually be there in the room at the same time. So you are doing a lot of education, and it's still inclusive of your rehabilitation. So please note that if you are bathing in your treatment time, that is included treatment time. So with our cardio patients that have a bypass, we actually see them in the afternoons with a bath, and we help bath the patient. So obviously with the rolling, then we do the chest physio, so they only get rolled once because obviously it's painful. And that goes for our very ill ICU patients that are ventilated, that have had major ops. Then even if you need to log roll, or there's a lot of examples where you can actually train other nursing professionals or carers to not pull the patient's arm, or this is how it's easier to roll, to bend this leg. And so just that you're aware, that is included in your rehabilitation time. All right. So moving on to our assessment codes now. A lot of people actually, we've noticed that there is not a clear line of understanding when it comes to a 701 and a 702. So I just want to give you an example. The patient was in ICU due to post-operative hip replacement. Physiotherapists did not treat the patient but charged a 901 702. Their explanation for charging these two codes was as follows. I went into the hospital to see the patient. I spoke to the nursing staff caring for the patient, checked the patient's vitals, and looked at the patient's files and x-rays. Due to the patient's condition, she was not stable enough for treatment. So, my question to you guys is the physiotherapist right in using the 702, and why? All right, so that's the only information that was actually given to Physiofocus for these two codes. And it actually comes down to the difference between the two is that the one involves clinical reasoning and the other one is a bit more standard, set, easy. Okay, so they actually justify that she is allowed to use a 702 because of her checking with the nursing staff, evaluating the vitals. So the vitals were clearly not stable enough, but she still took the time to read the patient's files and their x-rays. So she saw if, so obviously we don't know if the x-ray showed that the op took or not, but even just evaluating all of that and then actually deciding, using her clinical reasoning to not treat the patient. Because of the clinical reasoning behind it, she is justified in using a 702. So please don't get me wrong. Please don't start using 702s now left, right, and center. But it is not actually as time-based as we would have thought, okay? So normally your initial assessments should actually be 10-15 minutes long anyways, but we really use the 702. And knowing, there is a huge difference between the 701 and the 702. So we justify using the 702 when we are treating in rooms, and we do a full neurological assessment, we do a muscle testing assessment, check their gait, check their posture. We have this long list that takes us 20 minutes to do, as opposed to a 701, which takes us 10 to 15 minutes, reading the file, going through their vitals, checking with the patient, checking their hip range, checking if the nerve block hasn't affected, if they can do a straight leg raise, that they're safe to actually stand up. But your clinical reasoning actually behind it just does justify you to use a 702. So just understand that it is clinical reasoning and not time-based between these two codes. I know it does leave a little bit of a gray area, and it is something that can be discussed further. But use your discretion still. I think what's important to understand is that a 702 is actually quite a fraction more expensive than your 701, especially when it is in rooms. So please don't start overcharging for no reason. I think a lot of the time, if you do like the VBI test, that would justify you not to be doing your spinal lobes in the neck, testing neural dermatomes or your myotomes. That justifies you whether or not to refer on to the doctor, or to do a bit of neural glides, or is there a fracture, is there an impingement? So use your discretion, but understand the difference between those two codes. All right. So now we're moving on to the rules. There are two big rules that a lot of people actually don't understand how to use them. You have your two big rules. The initial one is your 008, which I'll show you in the examples to come. But I'm going to just go through the difference between your rule 009 and your rule 0010. So firstly, the first rule 009 is when more than one condition requires treatment, and each of these conditions necessitates an individual treatment. They shall be charged as individual treatments. The full details of the nature of the treatments and the diagnostic or diagnostic codes must be stated. Okay. So what that means is that you're treating more than one condition in an individual treatment time, okay? It obviously does increase the cost of the treatment, but for example, it would be a patient coming in and saying, "Hi, I am coughing, but my neck is sore." So you would literally be nebulizing and massaging. The times overlap in that sense. So you would do the two. You would have enough time to do the two treatments. yeah, that makes sense. So you are doing the two treatments, but you can overlap them. Okay. So for example, I have foot pain as well. Do you mind checking that quickly? So then you would spend 30 minutes on, say, the neck pain, and then 15 minutes on foot pain. So it would be two different conditions, and they can be charged as individual treatments. So your modifier 009 then must be quoted after the appropriate code number to indicate that this rule is applicable. This rule should not be used when more than one symptom is present and or areas of treatment stemming from the same condition are being treated. For example, cervical whiplash with pain radiating into the arm and upper thoracic area. So this is one condition, and thus you cannot use a 009. Okay, so a lot of us treat neck into shoulder into elbow. That is all one condition. It is not the rule of 009 to use them, because it is just more than one symptom. All right, so understand that it must be two individual treatments. I will show you on the table now how to use this. I'm just moving on to the 10. So rule 010 is when the treatment times of two completely separate and different conditions overlap. The fee shall be the full fee for the one condition and 50% of the fee for the other condition. So the modifier must be quoted after the appropriate code number to indicate that this rule is applicable, and the diagnosis of each condition stated with a diagnostic code. So the way that this differs, is that I actually made a mistake there, this is where you would do, for example, the treatment conditions would overlap. So this would be when you nebulize the patient. Okay, so you would be doing chest treatment. You can actually nebulize and massage their neck, so the two treatment times are overlapping, but you're doing both at once. So the best example I can give you is nebulizing and massaging at the same time. So it's not a longer treatment time, but it's still two completely separate conditions. Whereas your 009 would be like a foot and ankle, and you would be able to treat both conditions in the time, the 45 or 40 minutes allocated. Whereas they really do overlap. So then you would use the modifier 010. Okay. There is still quite a lot of confusion between these two rules, but understand that using these rules does not allow you to just do them to increase the cost of the treatment. You are using them for the applicability of doing two separate conditions. Okay, so when we look at the table now, for example, if you're doing a simple spinal treatment, you can see there that you've got on the first row a 501. So we're spending 40 minutes with the patient, massaging their muscles. I'm doing myofascial release, which allows me to use my 303. I'm explaining to them what kind of exercises they need to do. I'm correcting their posture, going through their ergonomics, what work they do, how are they driving. I'm doing a bit of spinal moves because they're actually quite sore. And they have a bit of neural, say median nerve neural tension. So I'm giving them median nerve neural glides. So normally in your 40-minute treatment, you have your 4 codes. Your first 2 codes are full codes. So whenever you charge a 501, the code after the 501 is also a full code. And then secondly, from there on, the codes that are used, you need to put the modifier 008 because that halves the cost of the code. So that's where the modifier 008 comes in, is that every 3rd, 4th, 5th, whatever time you're spending or codes using, you are modifying it to actually 50%. So we don't use 4 full-priced codes. We half the last 2 codes. and that's only if you're using a 501. So for example, if that wasn't a 501, if that was another code, then it would be a different sequence, which we'll actually pick up on the bottom, on the third row there. But then moving down to the second row, simple spinal and shoulder treatment for 40 minutes. So this would be like your back and shoulder, where they're unrelated. Please don't get me wrong, this is not a neck and shoulder, where I just pointed out that you can't do the two together. As you can see there, you've got on the first line would be for spine. So that would be a 501, 303, 401. So for the spine, we've done rehab, a 303, myofascial release, and spinal mobs, and your spinal mobs has been halved because it is the next code to be 50%. For the shoulder treatment, I've done a 302, which is massage, and then a 405, which is shoulder joint mobs, okay? So you can see that one is a full code, so I know it's jumped there, but you're allowed to use in the new condition one code as a full 100, so full code, but with the 009 it actually charges a 50%. And then the second code, you have a 008 and a 009. All right, so I don't know if you can pick up there that I've also not used any of the codes twice. You are not allowed to use myofascial release on the back, myofascial release on the shoulder, you're not allowed to repeat a 303 or a 401 or a 302. They all need to be separate codes, okay? So then just to show you then for, say, for example, a neck and knee, where you've put interferential, for example, onto the patient's knee, where it will overlap while you say still doing myofascial release or neural mobs. So you can see for the neck, the first coding is 303, myofascial release, 401, which is your spinal mobs with your 008, which halves that code, and then your 310, which is your neural mobs, giving it another 008 to half that code. Then for the knee, you've got a 405. Sorry, that was actually meant to be a 010. Yes, sorry, it was meant to be a 010. But you've got a 0010, a 107, which is half the code with a 0010, just ignore that 9, and then a 305 with a 008, 010. Okay, so that shows you of the two different, so you've got the overlapping of the interferential time, just so that you understand. Lastly, this hasn't actually been put on our system yet. At the moment, the laterality code does not help. I actually just put it in here to understand that the laterality code would then just be if you're doing a bilateral total knee replacement, which we see quite often. So we ended up treating two knees in the same treatment condition, in the same treatment time. So instead of using a 009, you would use a 018. But at the moment, our system doesn't actually allow for that. So it's just something to note that it is there in the future for us to use. But I'm going to move on from there. All right. So your rule summary actually is as followed. The additional cost, there is an additional cost involved when using a 009 or a 010. So please actually be aware that if you are using these codes, that they are an extra charge. So when that patient comes in and says, can you please check my ankle as well? You can say to them, that's no problem, ma'am. I just want you to be aware that it might actually be a little bit more for the treatment, because I'll be treating then two separate treatment conditions. So be savvy in your wording and, be open and honest. You can only use a 009 or a 010 when there are two separate conditions and not symptoms. So if there are different symptoms, it doesn't justify you to use a those codes. Okay, so it must be two separate conditions. So we come back to the cervical radiating down the arm. Those are symptoms. It's not two separate conditions. If you've broken your wrist and you have opposite side neck pain, it can also, be very gray. There could have been guarding or compensating, that kind of thing. So just really be accurate when you're going to use these codes. You cannot use these codes when the areas of treatment are related, so just like I just explained there. And you cannot give your patient an extra condition in order to increase the cost of your treatment. Obviously, it's unethical, so please don't do it. And you cannot use these rules to allow for longer treatment time, and that is fraud, okay? So if you are making your treatment time longer, just because you just want to use these codes, you really can't do that. So please be ethical. We definitely should not be doing that at all. But it's just good to be aware of that. Extending your treatment time so that you can use that extra code is you're committing fraud. All right. Okay, so we're just moving on to a bit of creative billing. This also comes down to the ethical use of billing. I know this is something that luckily we have quite standardized things, and our rates are according to, we are medical aid rates, so we are not luckily in any unethical boundaries, but just it's just good to note. So do your treatment first and then charge afterwards, okay? So just an example here is that, for example, if you use a 303, a 401, and a 501, the cost of their medical aid they would only pay 467 Rand for it, but our practice rate is 528 Rand for that code, for those combination of codes. So then the patient is liable for 61 Rand. So if our practice rates are higher than medical aid rates, we can't now change the practice rates to the medical aid rate so that the member is not liable. So that's why you'll see, or let's just show you at the second line, unethical coding, you add a second code in order to allow you to bring the practice rate and the medical aid rate up, so then the member isn't liable for anything. So that's called creative billing, where you're actually charging an extra code in order to let the practice rate and the medical aid rate almost be the same. So please be aware of creative billing. You can't just add a code here and there. Make sure that you're treating first before you think of your coding. You shouldn't actually be thinking of your coding. You should be doing your treatment and then coding thereafter. A lot of the time we have this stringent rule about having and spending the time and our quality of treatment, and we strive to do quality of treatment. I really feel like we love our jobs and we're here for the patient. But that doesn't mean that if your patient cannot cope with 30 minutes of rehab, that now you must push the patient for 30 minutes of rehab just so that you can charge a 501. That is not what we're here to do. If the patient can only manage 20 minutes of rehab, then they can only manage 20 minutes of rehab, and you would code accordingly. So please be aware of that. It's nothing set in stone. Use your own discretion and your own professionalism and your own clinical reasoning to justify what you're doing. We generally do undercharge, believe it or not. We are actually undercharged more than overcharge. But the more you know your codes and the better you know your codes, you will be safe. So just so that you know that, okay. And then I'm just going to touch on ICD-10 coding. This is a huge, actually separate presentation. It's a huge big baby. But it's just so that you understand that ICD-10 is the patient's diagnosis. It comes through all the specific books that they come from. They're actually a mixture of American and UK ICD-10 codes, which is standardized diagnoses. Please don't use the internet to look up ICD-10s because there are over 44,000 codes, and they actually aren't the correct codes because of this mixture of UK and USA. It's just really too broad. So luckily our Alexa system does allow you to search ICD-10 codes. So we actually, you must make sure that you're using the correct coding. So the best way to look up codes is by trying to remember to use the broadest descriptive word possible. So for example, we were really trying to find the code for vestibular rehabilitation instead of actually trying to search for vertigo. So we couldn't find the ICD-10 for vestibular. We kept looking up vestibular, but it was actually for vertigo. And then under vertigo, you have all the reasons of why you would have vertigo. So when you're using Alexa, go on, just try, see if you can find specific codes. Try and be as specific as possible. Another misconception is that when we treat post-operative conditions, so for example, your total knee replacement, it's no longer a total knee replacement when you're following up with them because they've had the knee op, so that ICD-10 has come and gone, if that makes sense. So now they have pain in their knee or they have stiffness in their knee. So just to be aware of that we are actually using our ICD-10 pain in knee or knee stiffness. There isn't, I don't think, a post-surgical knee ICD-10 code, but it's good to understand. The other thing is that we tend to use just that one specific ICD-10 code, but it has been noted that it is good to put previous conditions that are relevant as a sequel code, okay? So like I said, this is a whole separate presentation, but that just means that, for example, it's good to note if someone had a previous motor vehicle accident or a stroke, or that they're a cardiac patient. The list can actually be endless, and it's not actually documented, and the medical aid doesn't always know or consider these added conditions as well. So it is something else to note, that your ICD-10 coding is not wrong. If you're being called in, for example, an ICU patient, you would code the most primary conditions. So you're going in to do their chest because they've had respiratory failure. So your most relevant ICD-10 code is the one that's going to cause death, or is how do I say, like the most life-threatening ICD-10. So for example, respiratory failure would be your top, the very first ICD-10 that you use. But say they had respiratory failure due to a bypass surgery. So then your second ICD-10 would be, a bypass, graft. And then on top of that, they have diabetes, or they have a stroke, which is much. It's very important that you have those codes as well. But we are treating them, based on respiratory failure. So we're doing their chest, we're making sure we're doing the percussions, the vibes, the suction, and all of that based on respiratory failure. All right. So ICD-10 coding, it's crucial that you understand how to do your ICD-10 coding and correct giving the correct ICD-10. Okay, so that is the end of my presentation. I have made a questionnaire for you to go through and answer so that you can earn your CPD points. like I said before, please, if you have any questions or any queries, please feel free to contact me on Nadine at hdphysio.co.za. I'm more than happy to answer any of your questions. That being said, if I'm unable to answer your coding questions, then I will contact, or you can contact, Physiofocus directly to just give you some guidance. They're very happy to help, and they really want us to code as ethically as possible. So I really hope this has helped. And yeah, thanks everyone for listening. I hope that was not too difficult and confusing, and it just made you a little bit more relaxed in using the correct codes. All right. Cheers.